to start. Don't need to use that particular bit until after our first break. Right, I'm Matt Perry. I'm not sure if I've met you guys before, but if I haven't, I'm Matt Perry. I've been asked to deliver the session about ECGs. Now, what we're going to cover today has changed a couple of times in the last week, most notably yesterday. As I understand it, your physiology module has been slightly delayed, is that right? Yeah, about a week behind in some of the things, yeah. The original plan for this session was based on the fact that you would have had the physiology session that precedes this already, okay? So when I was asked to give this lecture, I planned assuming you'd have that knowledge. So the work I did into that planning I threw out yesterday morning because I discovered that you hadn't had that, so I've replanned it. As a consequence, today's session will not be disjointed, but we will jump from a couple of different presentations because I've included there some basic understanding that you need to have before you have the advanced understanding. Does that make sense? Mm-hmm. Yeah. So I need you guys to tell me at any stage if I've gone too far, if there's something that I'm assuming that you've got that you don't have. If you don't understand something, I need someone to pop up a hand and say, hang on a sec. Now, you might be the only one in the class who doesn't quite understand, but I doubt it. If there's one person, there's usually about half the class, okay? And I don't want to leave anyone behind. So, who knows a little bit about ECGs? Any volunteers to take my place and I'll sit in the audience? No? No. Who knows? You've all used ECGs before? Yep. You all come through the technician route? Yep. Yep. Who's comfortable with ECGs? Just a quick show of hands. No one. Fantastic. 10 years of clinical practice. I still get confused by them occasionally. Well, more than occasionally. I would like to consider myself fairly good at ECGs, and I like cardiac electrophysiology. In fact, I had a debate in the office yesterday with Keith and Martin, if you ever want a good debate. Monday morning, Keith and Martin, great time to have a chat. We were discussing the merits of ECGs and whether or not they add value to paramedic practice. Of course, I believe they definitely do. There were some dissenters in the room, I won't name Martin, but who basically consider most of it an added extra because it doesn't change practice. Okay? Now, I don't care what camp you belong in, whether or not you want to look at the finer points of ECGs, whether you want to consider how much impact that's going to have on your actual clinical practice. I look at the finer points of ECGs because there are parts of an ECG tracing that can tell me what my patient may experience in the next 15, 20 minutes, half an hour to an hour. Some people don't because often I can't do much about it. And some people prefer not to know stuff that they can't do anything about. Doesn't matter. It's individual practice. So, what I will teach you today, a little bit about cardiac electrophysiology to make sure that we don't leave any glaring gaps in that before we move on to the more sort of high-end stuff. A little bit about anatomy. I'm going to presume that you know basic anatomy already. We're going to have a bit more in depth about look at ECG tracings, cardiac electrophysiology. Yeah, sorry about that. My mum was always telling me to clean up my bedroom as a child, so I never listened to her. we're going to go a little bit more in depth about 12-lead ECGs and how to distinguish what is a good rhythm and what is a bad rhythm. I'm not going to teach you everything you need to know about 12 leads because I just can't do that, certainly not in a day. There is also a discussion forum which I've opened on your Moodle page. Some of you might have seen already if you happen to be up at 11 o'clock at night. I am because I've got two small kids that wake me up at 10, 11, 12, 2 and 4. The Moodle discussion is about extending your knowledge. It's not compulsory, you don't have to do it, but by the end of the day, the question that's on there should help shape the way you extend your knowledge. The question is about ST depression. Everyone's heard of ST elevation, I take it? Yep. Good old STEMI. So ST elevation is a good way of, well, not definitively, a good way of diagnosing a myocardial infarction that you can actually do something about. There are other types of infarctions that are more difficult to treat in hospital. But STEMI is one we know that is time critical and that you can do something about it in the hospital. My question on the forum is, okay, what about ST depression? ST depression tells us that there is damaged tissue. Why can't we use that to diagnose an infarct? And to answer that, you're going to have to do a bit of looking around. Okay. So what we'll start with is, if I can find it here, cardiac workshop, there we go. That was the original objectives for the day, that's somewhat changed. Who needs an ECG? Sorry? Anyone with chest pain? Yep. Yep. Anyone else? Sorry? Collapse? So, what might the story be for a collapse? Oh, you get there, what would they say? Sorry? Feeling dizzy? Yep. Blackouts. What happens if someone says, oh, I've ended up on the floor, I must have tripped over that rug because, it's got a corner and I've tripped over it before. Is that a fall or a collapse or an unknown?
They're just assuming that they're...
Yeah, there's a couple of clues in the language, isn't there? Any other reason you'd put on an ECG?
Certain medication to be given.
Like?
Yep.
If you give some medication, so there's adrenaline. What other medications might... sorry? Salbutamol? Ondansetron? Yep, Narcan? Amiodarone? Be a good idea to have an ECG on at some point. If they're alive. Any other drugs that you might give that after which you would want to see a Atropine? Well, you probably hope that you have an ECG before that because it might indicate why, but yeah. What other drugs can you give?
GTN.
Yeah, GTN. Again, you probably want an ECG on beforehand. What other drugs might you give that's not cardiac drugs that you might want to see a tracing of the heart afterwards? Sorry? Furosemide? Morphine? Why morphine? Is it morphine? Just naming drugs now, aren't you? Anyone think why I would put an ECG on after giving morphine? Why?
It's a depressant.
Sorry?
Depressant.
Yep. And what would that do?
Slow things down.
Slow, yeah. Depressant slow things down. What will that do for your heart though?
Increase.
Good to press it. Oh, right.
Yep, the heart rate might slow, it might slow too much.
Yeah.
It may bring out some arrhythmias as the heart rate slows. The heart rate might increase because somebody's blood pressure is dropping, and that may bring out some arrhythmias, some of which may be dangerous. Yep. Any other drugs that you can think of? What other drugs do we give? Diazepam, so similar to morphine? Sorry? Yep, some sedatrivin.
Not all that we give, or I hope not anyway, but if someone's had cocaine.
Cocaine? Yeah, I hope that we don't. Yeah, no cocaine. Yeah, absolutely. Drugs that other people have taken. So benzylpenicillin. What would that do to somebody's heart? We know what it does to somebody's bugs. It kills them. No, not that I know of. It's possible, but not what I know of. At a very basic level, we know a lot of people are allergic to benzylpenicillin, so you're going to be monitoring things like their blood pressure and other things for signs of a drop in blood pressure. Again, if their blood pressure is going to drop, you may want to see what their heart's going to do, because it may speed up extra strain on the heart. You may get arrhythmias starting to develop. So I would. Martin probably wouldn't. There is a difference in practice. What else have we got? We've covered atropine, we've covered adrenaline. So for most interventions that I do, I would probably put on an ECG. And that comes back to my philosophy of I want to know what's happening in all the body systems that I can monitor, so that I get enough data, I get enough information to try and predict what's happening for my patient. So for me, who gets an ECG? Well, pretty much everyone. Now, what does that result in? Sometimes I find incidental findings that had nothing to do with the reason I was called, and then I have to make a decision on, okay, now that I've found that, what do I do about it? So sometimes I put it on an ECG on a patient that my colleagues may not. I find an arrhythmia that they would not have found. I have to take the patient to hospital because I don't know if that's normal for them or not. They don't have to take the patient to hospital, and sometimes it is normal it's at home, so have I wasted a resource? Probably. But if I have to take them to hospital and they find that it is not normal, then I may have made a significant difference to the life of that person and the health of that person that nobody else has found because I put on an ECG. So, pros and cons. Again, I don't care which camp you're in, there's different ways of practicing. So, cardiac electrophysiology. Who understands that fairly well? Who understands it at all? Everyone know what a heart is. Fantastic. Okay, so there are certain pacemakers, pacemaker cells within the heart. Do we all know that? Yeah. So we've got a basic understanding. A heartbeat, what pacemaker group of cells does that start at? SA node. Where is the SA node in the heart?
Near the right atrium.
Near the right atrium.
Yeah.
The SA node is a group of cells sitting somewhere near the apex of the right atrium. It doesn't sit in the same place in all hearts. Each heart is slightly different. So the electrical conduction, I'm not an artist, I'm a paramedic. Electrical conduction sits at a group of cells called the SA node. How often does that fire off? Sorry? No, how often per minute? Depends on the person.
Depends on the heart rate.
What's a normal heart rate?
60 to 80.
Yeah, I'll give you that. Most textbooks say around there, or 60 to 100, or 40 to 100. So somewhere around that. So that group of cells fires off somewhere in there every minute. I've got a friend, by the way, whose resting heart rate is that. She's very, very, very fit. She used to do triathlons between night shifts. That's how fit she is, and crazy, anyway. So, electrical conduction travels down this way and it hits what group of cells? Hey, fantastic. AV node. What happens to it at the AV node?
So down bundle of this.
What happens before it gets sent down bundle of this?
Doesn't it sort through like the electrical activity? It sort of pauses, doesn't it?
Yes, takes a coffee break. Yep.
Sorts them through.
So coffee and donuts at the AV node. How long for?
4 seconds.
There's a bit of a range though. Anyone know the range? No? Okay, we'll come back to that. So AV node, bundle of his. Then where does it go from there?
75 minutes.
Yep. Now, simplistic diagram. There are a few little bits that cross over and a few little bits that cross back. So a slightly more complex diagram looks a bit different, but in general terms, SA node, AV node, bundle of His, Purkinje fibres. Okay? Does everyone have a good understanding of that? Have you been through this before in a tech course somewhere? Good. So, 3-lead ECG. How much have you covered with that? A lot? Yep. So can somebody tell me what's happening here? If you can see that.
Atrial systole.
Sorry?
Atrial systole.
Atrial systole at, what's this wave called?
P.
P wave. What's happening at the P wave? Depolarization. Yep, which means,
Which means the atria is contracting.
is it contracting?
What are you saying, right? You asked a loaded question.
Maybe the smile on my face might give that away.
Mm.
Atrial depolarization at the P wave. Does that mean the atria is contracting? What do people think?
Sorry.
Sorry?
Not necessarily.
Why?
You can still have depolarization of the tissue without contraction. You can still have electrical activity.
Yeah. And what's that called?
Yeah.
PEA. Well done. So, yes, generally speaking, you're right, it is. But make sure you get it in your head that electrical activity doesn't mean muscular activity. Doesn't always mean that. Generally speaking, yes. So P wave, at the start, that's where the AV node fires. We don't actually see the AV node firing. What we see is depolarization. Now, why is that a positive bump on our 3-lead ECG, on our lead 2?
It's going towards you.
Is it going towards or away from? Glass, separate. Why is it a positive bump? So lead 2, we've got a positive and a negative electrode on our ECG to try and capture this current. Right? Drawn on this diagram, it's there. Positive electrode, and this you can think of as a positive current or positive innovation. Okay? The general direction of this current is from the SA node to the AV node. It's travelling towards your positive lead. So positive depolarization towards a positive lead will result in a positive inflection on your ECG. Now, not all of the electrical current is actually travelling towards that terminal, is it? Some of it is going up here, some of it's going down here, but generally speaking, things are flowing down towards your AV node. Have I lost you yet? No? Okay. So positive depolarization towards a positive terminal will result in a positive inflection. So what's happening here then? What's that bit called? QRS. Somebody like to explain that?
It's going down the bundle of this into fibres and coming back round.
Yep.
So it's positive and negative because it's going back to the way.
Yep. So this bit here still somewhat positive. It's moving through here. And in particular, what bit of the heart, if the muscle reacts to the electricity and the muscle fires off and everything depolarizes as it should, muscle squeezes, what bit of the heart is mainly represented in this wave? Sorry? I heard left, ventricle. So left ventricle. What is special about the left ventricle? Sorry? Yeah, it's huge. It takes up the vast majority of the heart. The heart, and please quote this in your anatomy lectures, the heart is the left ventricle with a few extra pieces added on. That's all the heart is. Left ventricle and a few appendages. I see people actually writing that down, that's scary. So we're talking, the left ventricle here is a large piece of tissue, large muscle mass, therefore large electrical current to get it to contract. So can you see why we would have a large wave? You see why the P wave is a small wave. By comparison, the atria are quite tiny, aren't they? So large, positive goes here. As it comes around the corner and spreads back up through the ventricles, it becomes more negative and then returns to this line, which by the way is called what? Isoelectric line. Fantastic. So we've still got a mainly positive depolarisation. Don't forget it's also going down and this way and this way, but mainly it's still heading towards here until it turns the corner. And it's mainly coming to here, turns the corner, and heads back the other way a little bit. Yep. So, what's happening here? Let's take this section first. What section's that? ST. There can be a J wave in there, you're right, but I possibly drew one. Again, not an artist, I'm a paramedic. ST segment. What's happening in the ST segment?
Repolarisation?
Not quite.
It's like making sure the ventricles.
The T part of that, maybe.
Holes in the heart.
Yeah, absolutely nothing at all. Yeah. Yeah, it's like me in the morning. Absolutely nothing at all happens. Okay. So that's just as a pause. T wave. This one confused me for about a year. What's with the T wave? What's happening at the T wave? Repolarisation. Which way does repolarisation happen? Where does it start and finish?
The opposite direction, doesn't it? Start.
Okay. Anyone else? Yeah, you're right.
Oh, right. Yeah.
And that's where I got to after about 6 months. Okay, let's think about this one. Repolarisation. Are we talking about a negative or a positive charge?
Becoming more negative.
We can think of it in terms of a negative charge, yeah. Depolarisation, you can think of it as a positive charge. Repolarisation as a negative. So, if we've got a negative charge, how do we make a negative charge look like a positive inflection on an ECG? What terminal must it be heading towards?
Negative.
Negative. So therefore, in our now rather crowded and messy diagram of the heart, which way must this be going? Must be heading towards here. So therefore, repolarisation must start at the bottom of the heart. You all agree? Yeah. Now, does that make sense on a physiological point of view, from a physiological point of view? What's happening physically within the heart?
I suppose you would think that because it started depolarising from the top, you'd think that it would start repolarising from the top, but it doesn't. It starts the other way around, which is a bit weird. But
Yeah. It is. It is a little bit weird. But what does the heart need to do to prepare for the next beat?
Reset.
Yeah, refit, reset, refill. And that gives it a bit of time to do that. So it depolarises, repolarises. And if it didn't do that process, it might actually be a bit too quick in beating. So it's a built-in timer, basically. Yep. Now, I realise they've gone through a lot of, well, maybe not a lot, I realise you've gone through some electrophysiology stuff. And for some people this may be a bit basic revision. But it's really important to get it in your head that a positive depolarisation or a positive charge heading towards a positive terminal will result in a positive inflection. If you understand that, you understand axis, and axis is a dirty word to a lot of paramedics. As soon as you mention axis, they go, oh God, no. As soon as you mention that to a lot of paramedics, they go, oh no, you're an ECG nut, aren't you? Yep. But if you understand axis, you can understand 12 lead ECGs, 15 lead ECGs, an ECG that I did on my German Shepherd. Yeah, don't ask me why. I had an ECG machine, I had my German Shepherd, and I just thought, yeah, why not? You can understand any ECG so long as you understand that a positive depolarisation heading towards a positive lead will result in a positive inflection on the tracing. And I hope during the course of the day that will become a bit more apparent to you. Anyone lost? All right. So, out of the particular book that I found that, SA node, intrinsic rates we're talking a lot about, so that's if left alone, if nothing else happens, that particular pacemaker site will fire off at that rate, 60 to 100. AV junction 40 to 60, so if it gets nothing from the SA node, it will take over at a rate of about 40 to 60. Bundle branches 30 to 40, Purkinje network about 30 to 40 as well. Those are general guides. I have seen accelerated junctional rhythms which beat at about 150. I've seen the Purkinje network take over at 15 and the patient still be conscious. Don't ask me how, I don't actually know. So general guidance. In terms of anatomy, again, the SA node doesn't always sit where it is on the picture. It does move around a bit. People's hearts are different. Orientation of the heart and the chest is often different. But that's a general rule of where everything is. In anatomy books, you'll often see this. Don't mistake that for a large right ventricle and a small left ventricle. It's because of the orientation of the heart. I'll pass this around. I've only got one of them at the moment, so just have a look at it. If I had the parts, I'd be able to show you the real thing, but we're not allowed them at the moment. What I did in my training is actually take apart a cow's heart. And that's a very useful exercise if you ever get a chance to do it. These slides, by the way, I will make available on Moodle. It was my intention to put them up before today's class, but because of the replanning yesterday, I decided not to. So, PQRST waves, and there are a few. There's J waves, there's U waves, there's other waves that do come into ECGs, but those are the basic building blocks of your ECG. The ports in the AV node. We were talking before about the time frame that it takes. 0.12 to 0.2 seconds. Also happens to be your PR interval. So that's where that's represented. QRS, 0.6 to 0.1 of a second. And there are other things like duration of your P wave. What else have I listed that might be important? Duration of your P wave, QT interval, and other things that become important the more you know about ECGs. But at the moment, what we're interested in is that gap, that duration, and whether that's up and down in particular leads. Okay? So we'll go through more of that a little bit later. Just some pictures about, proper pictures from actual artists, going over what we've been talking about. One of the reasons I don't go through these first is because they're a bit sort of stylistic, a bit, they give a false representation of a heart, and I prefer to draw a circle rather than try to draw an accurate heart, because it's very difficult to represent a 3D object on a two-dimensional drawing. Now, again, this is one of the major concepts, a 3D object on a two-dimensional drawing. What we're doing by capturing an ECG is attempting to describe the working of a three-dimensional living object, a heart, by drawing a few squiggly lines on a piece of two-dimensional paper. And then asking our brain to look at it and imagine what's happening with a three-dimensional object. Okay? Now, when people say that ECGs are hard to interpret, and people say that, get two cardiologists in a room and they'll argue about any particular ECG, often even a normal sinus rhythm, they're right. Because it's not about saying this is definitely happening. It's not about saying this rhythm means this. It's about interpreting the rhythm using both your experience and your knowledge to interpret that rhythm to say what you think is happening. You don't actually know unless you're looking at it. And if you're looking at it, I suggest your patient's not in a good way, because their chest would be open and it would be quite nasty. So what you're trying to do is imagine the workings of a 3D living object by looking at a piece of two-dimensional paper with some squiggly lines on it. Very important concept to get in your head. So, how do we actually do this? How do we actually figure out what the heck this two-dimensional piece of paper means for our three-dimensional heart? Has anyone got any ideas about a structured approach to looking at an ECG? Have you heard of different ways of looking at it, different structured approaches?
It's working out, start from
Yep, so what are the basics? Yep. So basics, right. Any other basics?
Rhythm.
Oh, sorry, someone said regular, so rhythm. No, I'll just put regular. Sorry?
Is there a P wave?
P wave, we're interested in that, aren't we? So there's a P wave present. Followed by QRS. Any other thoughts about a structured approach? What's next? T-wave. Anything else? Is there anything between the QRS and the T-wave that we're interested in? ST segment. Okay, so we've got an idea about a bit of a structure that we want to look at. Now, I've come to realise that in my practice, I sometimes lack structure, and I sometimes enjoy the lack of structure. But I also realise that my colleagues practice in different ways, and they thrive on structure. Some people work like I do, some people work like some of my colleagues. I also realised that as paramedics we could learn a lot from airline pilots. Airline pilots have a whole bunch of checklists that they go through to make sure they don't miss anything, because if they miss something, plane crashes, everyone dies, and it's not a very good day. In some parts of medicine, there are a number of checklists that people go through, and I often ask myself, why don't we have a similar approach? For me, that takes away a bit of clinical freedom, but maybe that would actually improve my practice. So structured approaches can be very formal, like a checklist, you follow down through this, or a loose structure. And it's up to you how you want to practice. There are pros and cons to both. Has anyone heard of the 10 rules for ECG interpretation? Can anyone rattle them off the top of their head? I can't, but can anyone? No? Have you been taught them formally?
No.
Yes and no. Okay. All right. So, I think it was in the 60s, off the top of my head I forget who, but somebody came up with 10 rules of ECG interpretation. Quite a very structured approach. And it followed along the same lines of what you've come up with here, generally speaking. I did learn them about 10 years ago, and I forgot them about 9.5 years ago. If you're the sort of person that does crave those, they're very structured, that might work for you. I've tried to hit a middle ground in what I'm suggesting today with a 6-step approach which is used quite widely around the world by various resus councils, including the Australian Resus Council, and I think ILCOR, the International Resus Council, have moved to this as well. It's quite a simple approach, and in my books, when it comes to ECGs, if you start simple and then move to the more complex, you're better off, because if you start simple, can recognise sick people easily, it's good. If you start complex and you muck it up and you miss sick people, it's not so good. Okay? So you start with your basics, get that worked out, and then move on to the slightly more complex. And this is generally the model that I use. So, we want to know, firstly, is there any electrical activity at all? Now, I know it seems like a bit of a silly question, but it is worthwhile keeping that one in your head. We'll go through and explain this one by one in a minute. The ventricular rate we're interested in. Under this model, we actually jump straight to the QRS because we're interested in the heart rate first. And why we're interested in the heart rate? Because if it's way too slow or way too fast, we may have some immediate concerns and we may need to stop there. And we don't really care about P waves. Okay? Heart rate produces pulse, pulse produces blood pressure. Lack of blood pressure will kill you pretty quick. Okay? Is the QRS complex with normal or abnormal? Okay, using this model, how quickly will I diagnose VT? Pretty quick. Yep, using a structured approach. If I go through and analyse, is the P wave present, normal, that way, it's going to take me a little bit longer to get to that that conclusion that this is VT. And I really have to abandon that model in order to diagnose VT quickly, don't I? Whereas this model, yeah, there's electroactivity, QRS is pretty quick and it's wide. Right, well that's pretty much where I stop. Now I've got to do something about it. Okay, so now that we're satisfied that we're not going to die, or our patient's not going to die, is there any actual activity? So now we get back to our P wave. What does that look like? And is that related to the ventricular activity? And if so, how? And that's designed to look at our blocks and that sort of thing. So a very simplistic model. Yeah, don't laugh at the first one. It has been known to happen occasionally. I would also add in the electrical activity that doesn't make sense. Has anyone put an ECG on somebody? Sorry? Yeah. What do you get? Not always.
That's really thick baseline, isn't it?
Sometimes? Yeah, so that really thick baseline, then there's bucket loads of artefact. Yep. You can get another interesting thing. Pacing spikes. A lot of machines will interpret the waves from the bed as a pacemaker and give you pacing spikes. And you say to the patient, oh, your pacemaker's working well, and they go, I haven't got one. And you look at your machine and go, oh, right. So, the other thing to remember is asystole is hardly ever a flat line. It does wander about a little. So, electrical activity, we can look at that fairly quickly and go, yes. Now, slightly more complex. QRS rate. Different textbooks will talk about different rates for bradycardia. Some will talk about absolute bradycardia and other things. But generally, if it's under about 60, it's getting slow. If it's under about 50, it's generally considered medically significant. If it's getting around the 30s, you start to think, if my patient's conscious, how are they maintaining their consciousness? I've been talking to someone with a heart rate of just a little bit under 20. So your patient's not always unconscious, but you're not, that person was lying down with their feet up with some fluid and wrapped in bubble wrap. I'm not going to do anything to that patient because any lower than that, and it's going to be bad. So, QRS rate. Your ECG strip has markers on it. I hope all of you know that. Yep. Don't always rely on the numbers that pop up on the machine. Actually have a look. Print off a 6-second strip and go from there. Now, can someone tell me a rhythm where your heart rate may change a little bit, go up and down? AF, fantastic. So an AF.
PACs, PVCs.
Yeah, PVCs may produce a pulse. So generally when we talk about heart rate, we talk about it's synonymous with pulse rates. So yeah, PVC may produce a pulse. But particularly I'm interested in AF. If I wrote that someone has a heart rate of 80 in an AF rhythm, am I lying? Has anyone written down on paperwork that somebody's got an AF rhythm and their heart rate is a particular number?
All the time.
all the time. Yeah, I did that for quite a few years. It's wrong. Your heart rate in AF can't be a snapshot because it constantly changes, doesn't it?
And you line out the PRF thing.
Exactly.
I was just thinking, well, it was just
Yeah, give a rough idea.
An average over what time frame?
15 seconds that you did.
80 to 100, 60 to 120. How about 50 to 200, but then when I happened to see it, it was 80. Is that different? Am I interested in these bits as well? Yeah, very, very clinically significant, the range of heart rate. Now, the PRFs that I used to fill in didn't have room for that. I don't know any PRFs that do. And I don't know how you put it on the electronic ones, but all I used to do is there were lines across the bottom, three little boxes for a heart rate. I put the lowest one in the top and the highest one in the bottom, and then beside it I put AF variable rate, 80 to 100, because that is clinically significant. So if you can estimate it over a 6-second strip, do so. Don't rely on the machine to count it, because it may count things that aren't necessarily proper waves. It may count artefacts. Regular or irregular, the RR interval we're interested in. What's the easiest way to see whether or not that's regular or irregular?
Smooth them out.
Sorry?
Just moving along in the squares between your eyes. Position, if it's literally on one of the vertical lines.
Yep.
If it's regularly on the next vertical line, then that complex also moving.
Yep.
Within the main square.
Good method. Any other methods?
No.
Fold in half, mark it on a piece of paper. Yep. What I used to do is print off a huge long strip, rip it in half, turn the strip over, mark half a dozen, move that along, and if they were the same, it was regular. Yep. And that's fairly easy to do in the back of a moving ambulance. Other people, some of my colleagues carried rulers. I can never get the hang of actually carrying a ruler with me. QRS complex. So we're looking for anything less than 0.12 of a second. So 3 small squares. Anything more than that, we're getting wide. Now, when we talk about 0.12 of a second, what I've found is that a lot of ECGs actually fall right on that line. They're very annoying. They don't, then the textbooks are either thin or fat. In reality, they're always right on that line, or they're just slightly fat, and you're wondering if that's significant. But we're interested in anything that's over 0.12 of a second or 3 small squares. If it is thin, it's more than likely been fired off from the activity of the P wave, from the atria. If it's slightly fat, it's less likely. If it's fat, it's more likely to come from a junctional area of the heart. And we're definitely interested in that. Atrial activity, is it present? P waves should be present, they should be slightly rounded, not particularly peaked. They should be related to the QRS. If you don't see a P wave, it may be hidden within a QRS complex, and what you have to do is look at the different QRS complexes and see if they're the same. But we're going hunting for P waves because they indicate atrial activity. And is the atrial activity related to ventricular activity, and if so, how? And see in here, nothing happens. And here, something happens afterwards. And we've got to interpret whether or not this is happening as a result of that. And that's often where a lot of arguments lie over ECGs. You get a QRS, you get a P wave, and different people will have a different interpretation to say that this causes that. So what do you think in that particular wave? Do you think the P wave is causing the QRS? No, why not?
Because the Q, because they're different, the PR intervals different on each complex.
Yep.
PR.
So PR interval, well, there's no R, so the PR interval is forever. PR interval there. P wave or T wave?
T.
Could be either, really, couldn't it? So pop back here, is there a T wave? No. But then, is that actually a T wave? It's starting to get a bit difficult, isn't it?
Why are you playing with that? Why would you think it's a T-wave? Because I think it's a T-wave.
I would think it was a T wave.
Probably not.
T-wave is meant to be wider, or
Could be. But we've got nothing to compare it to, do we?
PRS complex is
irregular, aren't they?
They're regular, but then so are T waves.
Yeah,
There aren't any clear definitions of
You
T
wouldn't
wave
be-
after any VM.
This doesn't have a Q at all, and it is no pressure. This is just an R.
So more than likely to be a P wave, because T waves don't generally have a changing QT interval. Generally. They can, but they generally don't. Now, notice I haven't said definitely. So, we've decided, yes, that's a P wave. We've decided PR intervals are changing. So probably not resulting in this. And if we wanted to confirm our suspicions a little bit, we would have noted earlier that the heart rate is what? Slow. Yep. And it's wide. So having decided that these are P waves, having already found that we're Brady, we're wide, we've now decided that these don't result in these. Now, what if your colleague came along and said, well, I think this one does, because it's the right interval? What would you say to that?
it's just like,
There are others that don't.
Or you might say, well, that may be the case for that one. Who knows? But you can, you can say it's still wide, looks the same, more or less, looks the same. So I don't think that that's any different to that. Does that make sense? Yep, so what we've done there is we've used that 6-step approach, albeit in reverse a little bit. We've used that 6-step approach to diagnose that ECG. So tell me what's happening there. Yeah, one of them is not like the rest, is it? Sesame Street song about that, I think. Yep. So, someone has mentioned a PVC. Good, excellent. Great work. Pattern recognised rather than diagnosed. So let's go through and diagnose it using the 6-step approach. So where do we start? And is there electrical activity? Who disagrees? Right. Ventricular rate. What do you reckon?
Yeah, right, regular. Just looking.
Yep. So,
Roughly about 4 large scans.
anyone got a number? 2, 3, 4, 5. Yep. 60, 65, 70, somewhere around there. The PVC gets in the way, doesn't it? But are we happy with the rate? If it's 60 or 70,
Yeah.
either one reasonably good, depending on what's happening for the patient, obviously. Yep. QRS rhythm, regular or irregular?
Yeah, until it's quite. But you need to check using vitamin.
Yep. So without the ability to do all of those tricks, yeah, pretty regular, doesn't it? Apart from our friend at the end. Yep. What's the next step?
So it's
Yeah.
curious
QRS complex. Happy with that? Our friend at the end? No. Our friend at the end is what? A bit wide. So where's it coming from? Around, yeah, ventricular. Yeah. Because it's wide, it's got to come from somewhere around AV node or below. Is there any atrial activity? Yep. Does that look normal?
The last one, but you can't, they could be on the last one, but you can't see it.
Right. How would you know if there is? How would you go looking for atrial activity in our friend at the end?
Feeling pulse.
Probably wouldn't be able, you'd be able to find ventricular activity. So what I would do is go, okay, where do I expect the P wave to be? Well, before the QRS. So I have a look at this complex, and then I compare it to some of the other complexes. Now, if there's any atrial activity, that will impact on the way the machine records the rest of the activity. So, if I've got AV node firing off, activity coming down to the AV node, and then down to the rest of the heart, if that's all happening, and at the same time as, say, this bit of the electrical activity is happening down here, so maybe in this bit here, I've got something else happening up here, that's going to change the way that bit of the ECG looks, isn't it? So instead of, where's my toilet paper? Don't have any dusters here, unfortunately. So instead, well, it doesn't have quite that dip, but instead of having a wave like that, because I've got a little bit of extra positive inflection, I might have something that doesn't quite go up there, it's got a little notch in it. I might have something that even looks a bit smaller than the original. It looks different, basically. If it doesn't look different to the others, nothing else is happening. If they look exactly the same, or close enough, then I know there is no other electrical activity happening in that heart. So therefore, I can say there's probably no P wave hiding in amongst this. It won't completely conceal it. It's like me trying to hide behind the skeleton. You're still going to see me. You might not see all of me. You might not even recognise me. But you're still going to see me. Okay? So, is there any electrical activity in our friend at the end? Any atrial activity in our friend at the end?
Yeah.
Yes.
Yeah.
Atrial activity.
Is that ventricular?
Is it ventricular?
It's definitely ventricular, but they're not.
You're talking about that?
Yeah.
Yeah, that's more than likely to do with the way it travels through the ventricles.
Right.
It's not likely to be atrial. Could be, but it's not likely to be. Yep, good point there. So the general consensus is no, not really? Yep. Okay, so that extra beat is happening somewhere below the SA node. Probably at the level of the AV node. Yeah? Okay. How about this one? Tell me about this one using your 6-step approach. Yep, good start. Yep, are we happy with the rate? Not really. A little bit slow. Do we want to do anything about the rate? Yep, what does it depend on the patient?
Like young and fit, you might know it's just if they know their heart rate's already slow, it might be normal for them. They're
Yep.
aware of it, or if they're older and they're not aware of it.
It depends on the presentation, depends on the history. Sorry?
Any drugs are taken?
Yep. Depends on the history. What's next on the list?
Regular.
Is it regular? Yeah, it looks pretty regular. Again, hard to tell without you measuring up. Next on the list? Yep. What do you think of those? Yep, pretty normal. Atrial activity? Yeah. Is it related to the QRS? If so, how?
You get one of them beat.
Yeah, so we've got a QRS after every P wave and PR interval. What do you think of the PR interval? It's all the same? Pretty good? And they appear to be related, don't they? Yeah. Tell me about this one. Sorry? Pattern recognised? Yep. So you saw it on the machine and your brain just went VF. Let's have a look at diagnosing it. Now, pattern recognition of VF is not a bad thing. Generally, it looks squiggly and they're dead. Chop them. But doesn't always cut it for, in particular, VT, and we'll get to that much later in the day. So let's go through and diagnose this. First step. Yes?
Yeah.
No one's calling that asystole? No? Next.
158.
Somebody's reading off the machine? Yeah. QRS rate.
Good luck.
Now, what are you going to call your QRS in this one? Sorry? Well, is there a QRS wave? No. And why not? What's happening within the heart? Why do you see a disorganised jumble up here? Yeah, it's a disorganised jumble in the heart, isn't it? The electric activity is going all over the place. Now, it's not firing off, in terms of its strength and the cells, it's not firing off any differently to the individual cell, but it's not going in any organised direction. It's just going everywhere. Okay? So you really can't go any further on that one. Now, I do say make sure you don't pattern recognise. Do diagnose, but you can diagnose this in a couple of seconds. Yep. Or even less. So this one here. It's not the last ECG you'll look at today, but it'll be the last for this section. Oh, actually, no, I've got one more that I like. Second to last. So this one here. Electric activity. Next. Sorry? Ventricular rate is yeah, it's getting a bit slow, isn't it? Yep. QRS rhythm. Regular or irregular? Regular. Yep. QRS complex width. Wide. Which means what? Coming from somewhere below the SA node, isn't it? Atrial activity. Yep. A wave look about normal? The wave by itself? Yep. It's not notched, it's not peaked, it looks pretty good. Is it related to the QRS?
No.
Sounds fairly definite over there. Yeah, and we've seen that one before, haven't we? So, when you get used to the system, your brain will go, electric activity rate is 1, 2, 3, 4, yeah, 55-ish. Yeah, rhythm's good, QRS is wide, I don't see any P waves. Yeah, so that's a junctional rhythm, it's slow, so... See what I mean? You get used to doing that fairly quick. Don't worry, we will add in things like ST elevation at some stage. Electrical activity, well, no, that's artefact, he's dead. Oh, tell me about this one. That's a real tracing, by the way.
Yeah, it's been shot.
Yep, and what's happened afterwards? Where's he been shot?
Full that.
At what point in here?
The start of that fat line, isn't it?
The pause.
There.
Yeah.
Okay, so tell me what's happening here.
I can't see it.
Can't see it? Yeah, it's a bit difficult to see. Basically, there's an upward inflection, comes down, and then there's a little bump, but it doesn't really look similar to the P waves. And then you've got that bit, which looks similar to these. So if we go through our 6-step approach, yes, there's electrical activity. What's next?
What's that?
Yep, we've looked at the ventricular rate, QRS complex is regular, irregular? Regular right from the start? I mean, from the start of the...
Yeah.
Yeah. Yep,
Is it wide? No.
not wide. Atrial activity?
Yes.
Yep. Now, looking a bit closer at atrial activity. For those that can see, sorry it's a bit small, the first one, first P wave, and the rest of them, are they all the same?
Yeah.
Yeah? Or no?
They're not the very same, so they're not. That's slightly shorter.
Bit rounder towards the beginning, and it gets more defined as a shape towards the end.
Yeah. So keep that in the back of your head. Now, are they related to QRS complexes? And if so, how?
Swans and all.
The PRS will just look quite regular.
Yep.
So, yeah.
Yeah, okay, they are related. Now, the P waves. This one we know that they've been shocked. We know we've got a rhythm back. We know that it's reasonably quick. From our diagnosis of the ECG, we know we've got P waves that are associated with QRS, but we're a little bit interested in those P waves and what they're doing. Why would I be interested in those P waves? Yeah. I've shocked this person, they've come back, and now their heart's working as it should. P wave, there's no particular issue with conduction. I'm not seeing a wide QRS, I'm not seeing anything that would indicate why this person has been in this rhythm here, except my P wave is not the same each time. There are very subtle differences through that P wave. So what am I going to do? I'm going to keep an eye on that P wave. I'm going to see what happens, because if that P wave starts to change markedly, that might be an indicator that that person might arrest again. Yeah? Not saying that that's the case for this one, and that some of those changes are very subtle. I might not even see them in the back of a moving ambulance, but if there's anything different on that ECG, I'm going to look at it to see whether or not that's going to indicate whether this person's going to arrest again. Some types of PVCs are an example of that. Speaking of PVCs, what have you been told about PVCs? What do they mean? What do they not mean?
Extra.
Extra beat?
A lot of people have them and it doesn't cause them any problems.
Is that always the case? If you saw that rhythm there, would you be concerned? Bigemini, trigemini? So PVCs are the subject of a few myths around in paramedic practice. Myth number one is that they're always benign or don't cause any problems. And myth number two is that they always cause problems. In my experience, the people who believe that they don't cause any problems are people who have thought that in the past that they may cause problems. They highlight it to the hospital, doctor leaves, oh, don't worry, it's just a PVC. And they take from that they don't cause any problems. Now, that's not true. There are types of premature ventricular contractions or conductions that do cause problems. The ones originating from the right ventricular outflow tract, which is a particular area of the heart that connects the left ventricle and the right ventricle, 90% of the time they will go on to cause a VT. The ones that originate in other locations other than the RVOT, 90% of the time they won't cause any problems at all and are quite benign. So both camps are right. Now luckily, the ones originating from the right ventricular outflow tract don't occur that often. The vast majority of the ones that you'll see are the non-RVOT. Now how do you tell? By a good knowledge of and a good understanding of the fact that a positive current travelling towards a positive electrode will cause a positive inflection on your ECG. If you know that, you can pick where a tracing on your ECG is coming from. So I'll leave you with that thought. We'll take a break for 10 minutes. And back here.